will move to our second speaker, who is Dr. Swati Patel, who's an Associate Professor of Medicine. She's also the Director of the Gastrointestinal Hereditary Cancer Centre, which I find very hard to say, on campus. And her research interests are very well supported by the NCI, Department of the VA, PCORI. She's very well funded. And Dr. Patel just came back from a trip that was very prestigious. She was an invited guest at the recent White House Cancer Moonshot Colorectal Cancer Forum. So thank you for joining us today.
Thank you so much for having me. It's really nice to be here, see lots of familiar faces I haven't seen in a long time. So I thought I would spend this first invitation to RIC talking about a clinical question that really made me commit to a career in clinical research. I do get research support from Olympus, though that has nothing to do with what we'll talk about today. So I'm going to try to convince you that hereditary syndromes, even though many see them as rare syndromes, are actually quite common. They're associated with a high risk of multi-organ cancers, and we have really effective risk reduction strategies. There's a gap, and with every gap, there's an opportunity. Unfortunately, these syndromes are grossly under-recognized. And then I'll talk about really the clinical conundrum that I was banging my head up against a wall about several years ago that really caused me to think about it in a bigger way and think about kind of the research approach to actually answering that question, a novel approach to identifying these patients, and then show you some preliminary results associated with this. So this all started with a patient. This was years ago when I first started my practice here at the University of Colorado. A 34-year-old young man had diabetes, had an appendectomy. He was finishing his subspecialty fellowship here at pharmacy. And he actually came to us for a colonoscopy. So I met him right before the procedure, and he mentioned that he had been having intermittent bleeding. And on brief review, in the 30 seconds that we talked to patients before their procedures, mentioned that he has some family history of cancer. Did the colonoscopy, and he had this large polyp in his rectum. And perhaps that may have been associated with the cause of his bleeding. It was really satisfying as a gastrologist at that time to be able to remove that and know that this precancer polyp was taken out completely. Based on that large polyp and the fact that we removed it in several pieces, we asked him to come back in a few months just to make sure that it was completely removed. School life got in the way. We did come back approximately 10 months later, had a full colonoscopy at that time again. And thankfully, that site where we removed that polyp, that's a really nice appearing post-polypectomy scar with no evidence of recurrence. But curiously, actually had another fairly large-sized polyp on the other side of his colon that really wasn't seen removed on his procedure. So we took that one out as well. Based on contemporary surveillance guidelines, he was told to return in 3 years, which is what our multi-society task force recommends for patients who have these large polyps that are completely removed. Life, family got in the way, and he came back 6 years later. And even though it was for surveillance, he admitted, this is when I met him, that he had been having some abdominal pain, and his spouse had encouraged him to come in, and he was diagnosed with a cancer. Of course, he went through the entire process of hereditary risk assessment, this young patient, and was found to have a pathogenic variant in MLH1, which is consistent with Lynch syndrome, the most common hereditary GI cancer syndrome. And if we think about his life, this is a young man, unlike many others, who actually did have contact with the medical system throughout his early adulthood due to his diabetes, his surgical history. And then, we met him in our GI system at the age of 34, and he seemed to present with some red flags. This large polyp that had advanced precancer changes, and in fact, a second kind of medium to large size polyp. And time passed, and he had 3 kids over that period of time. And unfortunately, as time passed, not only was he diagnosed with cancer of the colon, but he also reported, as we got to know him, that his sister was diagnosed with endometrial cancer as well. So hereditary syndromes are quite common. In fact, Lynch syndrome affects 1 in 279 individuals in the United States. And that's actually more common than hereditary breast ovarian due to pathogenic variants in BRCA1 or 2. It's just issues that we don't see as much in terms of getting attention. And when we think about all patients with cancer, if we do comprehensive multi-gene panel genetic testing in all patients with cancer, no matter how young or old, no matter what their tumor looks like or their family history, 10% are going to have a pathogenic variant in one of these cancer predisposition genes. When we think about patients under the age of 50 who are diagnosed with cancer, that estimation actually pushes 16 to 25% of patients. And so our current standard of care is that every patient with colon cancer, and in fact endometrial cancer as well, should be screened for the most common hereditary syndrome, Lynch syndrome, but that every patient diagnosed with cancer under the age of 50 should be offered comprehensive genetic testing. We know that the cancer risks are high. Talked about colon cancer risk compared to the general population. Patients with Lynch, for instance, can carry up to a 60% lifetime risk of colorectal cancer. And you can see that there's a multitude of cancers that are increased risk in patients with these hereditary syndromes. Thankfully, we have very effective interventions along the cancer spectrum, from prevention all the way through treatment and survivorship. For those who have the syndrome, the genetic variant, but have not developed cancer yet, we have very effective prevention strategies, including medications. For instance, aspirin significantly reduces the risk of colorectal cancer in Lynch syndrome patients. We know that recent data just published last year shows that resistant starch dietary modification significantly reduces the risk of cancers outside the colon in Lynch syndrome. Everyone's familiar with risk reduction surgery. If you don't have an organ, you can get cancer. And so we uniformly recommend our Lynch syndrome patients to get, for instance, prophylactic hysterectomy, similar to our BRCA1 and 2 patients who are offered prophylactic mastectomy as well as hysterectomy and oophorectomy. And then, of course, my bread and butter. We know that colonoscopy with polyp removal is associated with significant reduction in the risk of getting colon cancer, as well as the risk of dying from colon cancer. For those that are diagnosed with colon cancer, our treatment is really quite specific and tailored to their hereditary syndrome. And this is in large part because not only is that patient at risk of getting the cancer that you're trying to treat, but they have a risk of a second cancer down the line. And so, for instance, individuals diagnosed with colon cancer are offered a more extended colectomy to decrease the chance of them getting a second cancer on the other side of their colon years down the line. They're also potentially offered associated risk reduction surgeries at the same time, like partial colectomy with a hysterectomy to reduce the risk of a cancer in another organ. And then, of course, for our patients who have more advanced disease, we all know the really powerful benefit of tailored chemotherapy regimens, such as immunotherapy in microsatellite unstable tumors. Oftentimes, even though we practice medicine with the patient in front of us as top of mind, what's really important to know is that we know how these syndromes are inherited through the family. And so what we can really do is once we identify a patient with a hereditary syndrome, we can systematically march our way through the family, identify those who may be at risk, perform genetic testing, identify their family members as a cascade throughout the family, and very efficiently identify individuals who could benefit from cancer prevention interventions. So we have this powerful opportunity to not just implement this cancer risk reduction for our patient, but really for all of their family members who may be at risk. So in that very brief overview, I think it's quite clear that these hereditary syndromes are much more common than we realize. They're associated with a significantly increased risk with multi-organ cancers, and we actually have ways to intervene and reduce that burden of cancer, not just in our patients, but their family members. So the gap. Well, unfortunately, these hereditary syndromes are grossly under-recognized. This was a modeling study performed back in 2011, and maybe we're doing a little bit better now than we were then, but this study estimated that less than 2% of individuals with Lynch syndrome in the United States are even aware of their genetic diagnosis. Why is that? Well, we certainly can't review all of the different barriers there are to identifying these patients and families, offering them genetic counseling and genetic testing services. But in general, our historical approach has been to focus on individuals with a family history of cancer or a personal history of cancer. And anyone who practices medicine, even if it's in hospital-based medicine, knows that we don't do a very good job of systematic collection of multi-generation family history, specifically cancer family history. And even if we are able to collect it, clinicians don't necessarily do a very good job of acting upon it to know what to do with that family history in terms of who would benefit from genetic counseling or genetic testing. When we think about those with cancer, we say, well, if it's a challenge to collect family history and act upon it before somebody gets cancer, what if we focus on the folks who have cancer and see if a hereditary syndrome drove that cancer? That's actually been a huge push in the field, including support to screen all patients with cancer for the most common hereditary syndromes, and more recently, perhaps to even offer genetic testing to all patients with colon cancer, which we already do for ovarian cancer and pancreatic cancer. But again, for those who take care of patients who have cancer or had a family member, a friend who's been affected by cancer, there's a lot of other competing problems and priorities that cancer patients have. Whether it's trying to focus on treatment in the context of balancing family and other responsibilities, sometimes it's perception of futility. I already have cancer, what's the point? As well as systemic issues that because there's this diffusion of responsibility in the setting of a patient to be diagnosed with cancer, and because genetics may or may not change the today, tomorrow, that perhaps the referral doesn't get placed. So we certainly have lots of barriers to overcome in our traditional approach to identifying these patients. Not to mention all the logistic issues that our patients deal with: travel, access, cost. So I think within this lies the opportunity that I wanted to really examine. So when we think about our patient, he told us at the age of 34, perhaps that there was something high risk going on in his colon. And though we interrupted the natural history to cancer, perhaps that could have been a red flag for hereditary syndrome. There certainly was an opportunity, if found at that time, to really change the course of his life and his family's life. Entirely possible that that cancer, if not prevented, could have been found at an earlier stage. Certainly could have offered him and his partner pre-implantation genetic testing, genetic counseling services if they were interested in that, and impacted the future of their 3 children. And then, of course, knowing about this within the family would have potentially impacted his sister's battle with endometrial cancer. So what I wanted to do in sort of thinking about this situation and kind of coming outside of my GI endoscopy narrow box was really to think about whether we can leverage this really powerful kind of intervention that we have in medicine, that even though we remove the polyp, but to take a step back and think about the fact that we don't actually change that patient's underlying risk of what drove that polyp to form into a cancer. What we know is that we do colonoscopy a lot. Recent estimates suggest that we do about 15 million a year, and it's increasing. As many are likely aware, we're expanding screening to younger patients, which is a great advance in improving colon cancer risk reduction. And we know that about 7 to 10%, depending on the population, will have one of these advanced polyps. And so potentially, this could be a patient population that we could target to really improve identification of hereditary syndromes. And so that's really the question that I wanted to address. What we know is that these patients, if we were to offer them genetic counseling, genetic testing, may not necessarily face the same barriers as patients who may not know their full family history, or patients who are dealing with what cancer patients have to deal with. What we don't know is what we'd expect to find if we did multi-gene panel genetic testing in these individuals. And because we don't have the answer to this question, at present, the National Comprehensive Cancer Network really doesn't support germline genetic testing in these individuals. They certainly will offer genetic testing to patients who have a personal history of cancer, a family history of cancer, but this pre-cancer zone is one that we just don't have a lot of data on in terms of what the yield would be. So we really looked at assessing what the yield of expanding genetic testing to those with advanced polyps, these advanced adenomas, would be. And my hypothesis was that, in fact, if we really do think of these as cancer equivalent, that the yield of genetic testing may very well be similar to those that we expect in patients who have cancer. So approximately 10% in all comers, and maybe even higher, 16% in those diagnosed under the age of 50. So we went about identifying a cohort of individuals with these advanced polyps. We wanted to include any patient with a large polyp with these high-risk histologic features, and initially with an expanded kind of age criteria. Of course, we didn't want to include anyone who already had a known syndrome or had genetic testing already, or other risk factors for colon cancer, such as colitis or inflammatory bowel disease, a personal history of cancer in the past, or if there's kind of missing information. We started with the University of Colorado Polyp Registry, which very conveniently tracked patients who had colonoscopy at the University of Colorado, what their polyp results were, and identified patients initially through that registry. Unfortunately, that registry kind of stopped being maintained after 2017 or so. So then we worked with Compass to do kind of a poll. And the advantage of that was that we were able to expand our cohort to UC Health sites across Colorado. And so pulling Compass polls to identify patients who had a colonoscopy and had one of these advanced polyps. These individuals were invited to participate in our study. We collected some baseline characteristics via survey, family history, connected them with our cancer genetic counselor, Michelle Springer, who performed telehealth genetic counseling, mailed saliva kit genetic testing, and then these individuals had their results disclosed to them. And we started this study pre-pandemic, when things like telehealth services, mailed saliva kits, there were a lot of question marks around those. And really, as we all know, it's kind of evolved as a co-standard of care at this time. So thankfully, our research did not have to take too much of a pause for this project throughout the pandemic. Our goal was to really try to identify approximately 200 patients to give us a narrow enough confidence interval for our prevalence estimate. And although the sample size is limited, that would allow us to at least do some bivariate comparisons among those with a pathogenic variant versus those who didn't, based on risk factors collected at baseline. So far, we have 122 individuals who have completed genetic testing thus far, several more that are kind of in process at the moment. And just to kind of point out some characteristics associated with our cohort, the vast majority are between the ages of 40 to 59. Really, I think because of the source of our cohort, the University of Colorado and the UC Health system, the majority are white individuals. And most of them, in terms of habits, lead a fairly healthy lifestyle. Most don't actually take aspirin, don't smoke, don't have diabetes, and exercise some degree. In terms of the reasons they got colonoscopy, you can see that many were referred for screening, surveillance, but approximately 40% were referred due to symptoms, the most common symptom being bleeding. And in terms of the polyp that kind of allowed them to be eligible for our study, the majority were a combination of a large polyp as well as high-risk features under the microscope. What's really interesting is that the majority of the polyps that we found were located in the left side of the colon. And for those who maybe follow sort of these trends that we've been observing in patients getting diagnosed with cancer at earlier and earlier ages, that's in fact what we find is these patients with cancer in the rectum and the left colon. And the majority didn't have other kind of polyps at the same time, or in the past or future, and then the majority had not a large number of polyps, less than 10 polyps. We haven't dug through kind of the details of all their family history, but what I can tell you is that only 13% of these individuals actually meet current genetic testing criteria. And that's, of course, based on a personal history of cancer, which were exclusions for this study, and a family history of cancer. So what have we found so far? This is just data that we're starting to look at. We're, of course, short of our goal sample size, so we continue recruitment. But 15% of our cohort thus far have a pathogenic variant in a gene that's associated with cancer risk. Now, with that said, we sort of look at these genes as the high-risk, high-penetrance genes, such as the Lynch syndrome genes or BRCA1 and 2. And then there's a variety of other genes included on these panels that are associated with a moderate or lower risk of cancer, but still nonetheless associated with guideline-based recommendations for prevention. And then, as expected, over 40% had what we call a variant of uncertain significance. variants, which is common when we do multi-gene panel testing. When we look at the individuals found to have a pathogenic variant, we identified 3 patients with Lynch syndrome. We identified multiple other pathogenic variants that are associated with guideline-based recommendations for cancer risk reduction, not just in the colon. For instance, CHEK2, we recommend starting colonoscopy screening earlier, doing it more frequently than the general population, but also other organ-based risk reduction measures, such as more intensive breast cancer surveillance, as well as skin exam, pancreatic surveillance for ATM, for instance. So really implications for multiple organ cancer risk reduction. What's really interesting is that out of the 18 patients found to have a pathogenic variant, only 2 actually meet current genetic testing criteria based on the National Comprehensive Cancer Network guidelines. So our initial takeaways are that advanced adenomas may very well be a red flag for hereditary syndromes. The majority who were found to have a mutation don't meet current criteria, so these are not individuals that the system is just not capturing based on the current barriers, but really perhaps tapping into a population of patients that might prompt us to change the current criteria. And as colonoscopy uptake increases, that's a great success in cancer prevention as we take these polyps out, but targeting advanced adenoma patients may very well be an additional efficient way to identify these patients. So we certainly are working on continuing to expand this cohort. We'll start to look at some of the bivariate associations to see if there's subgroups that perhaps have a higher yield when it comes to germline genetic testing, whether that be based on age, whether that be based on other factors collected. So really looking forward to kind of learning more as we approach the sample size that we're hoping for. So this work was really the start to a lot of the research work that I've been doing, and supported by the Cancer Center here at the University of Colorado, as well as the Cancer League of Colorado, and as currently funded by the American Cancer Society. Lots of individuals to thank, mentors, colleagues, collaborators, but in particular, I'd like to give a special shout out to my mentor, Dr. Dennis Onen, who inspired me to commit my professional life to colon cancer prevention and continues to inspire me. Thank you.
So Swati, how, so the threshold for cancer screening, or the threshold for this screening that you're doing, what's it going to take to get us over that hump? Where we start to screen more individuals?
Yeah, I think data. So you mean what's it going to take to improve identification of the entire pie? Well, a lot of my friends and colleagues have been battling the family history battle for a very, very long time, including Dennis. There's no reason not to continue that, and I think there's sort of more implementation science ways to get at that in terms of leveraging the EHR to have patient-entered information that's collected and then acted upon, maybe taking the clinician out of it a little bit. And on the cancer side of things, I think one of the biggest disruptive changes, which is already in progress, as of 2022, the NCCN actually recommended doing germline genetic testing in all patients with colon cancer. I think that's going to be huge. It was a considered recommendation, but I think that's where things are going. The data supports doing so. I think it's more a logistic challenge of how do we accommodate the 4th most common cancer, 2nd leading cause of cancer-related death, 150,000 people diagnosed every year, not to mention everyone who's historically ever been diagnosed, in a system that already has limited genetic, counseling, genetic testing access. So I think there's sort of a gradual rollout on how to implement that. I think that will be a huge step forward, but again, that takes these patients that we scope and take big polyps out of the equation. And so I think if this study, we really wanted to collaborate with Denver Health and have a much more diverse patient population. There's just barriers to doing that, but I think more studies that look at this question of yield of genetic testing in advanced adenoma patients, I think that kind of bridges that continuum. But collection and action on family history is really, really hard, and it's inefficient because even patients who have, high-risk family history, with the modeling kind of tools that we have available, there's only still a 5 to 10% probability that we'll find a syndrome.
So within your terminology, how do you define colon cancer? Is it an adenoma? Is it a?
No, cancer by definition is invasive, right? And an adenoma is confined to the mucosa or the submucosa. But cancer technically is invasive, but clinically, and I know this is being broadcast via Zoom, hopefully none of the insurers that I've worked with over the past are tuning in, but when I first clinically encountered this, a young 25, 28-year-old with a large polyp, I would use creative terms like neoplasia, or tumor, and that's not dishonest, but that was the way to get genetic testing covered, or patients would pay out of pocket. And we started to see the signal clinically, and so I just decided to try to do an unselected cohort and truly describe the yield of genetic testing.
Can I ask what the barriers are in terms of the capacity for genetic counselling if you expand genetic testing? Because that's something, they're two things that go hand in hand.
Yeah.
And if you expand one, what's the plan to expand the other?
Yeah, I hope some of my genetic counseling colleagues are tuning in and they will certainly correct me. But the model for genetic counseling and genetic testing has been evolving. And traditionally, it was a referral to a genetic counselor who would collect a multi-generation cancer family history and spend a great deal of time talking to patients about their risk, the medical kind of implications of doing genetic testing, the non-medical implications, things such as life insurance, protections from discrimination. And that's a very intensive process. And sometimes our counselors will spend 90 minutes with a patient to go through all of that. However, with, programs that, our guidelines that recently over the last few years recommend testing everyone with ovarian cancer, everyone with pancreatic cancer, and now probably soon everyone with colorectal cancer, there's evolving models of delivering that service where something called mainstreaming is happening, where clinicians embedded in either multidisciplinary clinics like we have here, or other individuals who provide care, such as oncologists, perform the genetic testing with kind of some standardized educational materials, whether that be in video-based format or kind of some type of module, and then patients get genetic counseling after the fact, if they have a pathogenic variant, or then they get plugged into the appropriate care. And I think that's where the field is going, because we just don't have enough genetic counselors to offer that service to everyone.
That's a great talk, thank you. I was just interested, do we know the mechanism of action by which aspirin prevents development of cancer in patients with lesion? I thought it was fascinating.
Yeah, it is really fascinating. The short answer is no. We thought it was the COX-2 pathway, which we know has chemoprotective properties in the general population of colorectal cancer. But in 2020, the same group, so this was a randomized controlled trial that randomized patients to 600 milligrams of aspirin and the other half to placebo. And they found a 50% risk reduction in the intention to treat analysis. But what was fascinating is that these patients were recruited from European countries where there's long-term registry follow-up and very accurate kind of assessment of cancer risk long-term. And in 2020, they published their 15 to 20-year follow-up, and that benefit, despite being on that intervention for only 25 months, persisted 15 to 20 years out. So when you ask the question about mechanism, right, that really brought up all sorts of question marks, because initially we thought it was really just, the COX-2 pathway and chemoprevention, as we kind of knew it. But now there's questions about whether salicylate as a compound, the anti-apoptotic properties, actually may cause early changes in the gut microbiome that then confer, protective benefit 15, 20 years out.
Is there something unique or known about the location where the cancers are being found, the left colon and the rectum versus the right?
Yeah, so for these hereditary syndromes like Lynch
It kind of goes
syndrome,
to the microbiome.
yeah, well, for the hereditary syndromes, kind of the topic of today's lecture, they tend to be on the right side of the colon, the ascending colon syndrome. But for these patients, another kind of major area of my interest is in patients getting colon cancer at young ages where there's no hereditary syndrome, it's early age onset kind of colon cancer phenomenon. And for those patients, the vast majority occur in the rectum and the sigmoid colon. And we don't have a full explanation, but there's lots of hypotheses around differential microbiome, also, various kind of exposome changes that really affect the left colon kind of differentially in the right colon.
Well, thank you for being with us today.